Welcome to this clinical masterclass on intestinal obstruction. Intestinal obstruction occurs when there is a partial or complete impairment in the forward passage of digestive contents through the gastrointestinal tract. When this normal anterograde peristaltic movement is halted, the physiological balance of the gut is drastically disrupted. Look closely at the central anatomical illustration. At the exact point of obstruction, whether caused by a physical mechanical barrier or a metabolic failure of peristalsis, content progression ceases completely. Immediately proximal to this site of blockage, digestive secretions, ingested fluids, swallowed air, and bacterial fermentation gases accumulate rapidly. This progressive accumulation causes extreme intraluminal pressure, leading to massive proximal dilation of the bowel wall. Notice how the intestine above the blockage stretches and distends. Conversely, look distal to the point of obstruction. Beyond the block, no fluid or gas can pass. As a result, the distal segment of the bowel empties completely and becomes entirely collapsed. Understanding this mechanical dichotomy, proximal dilation versus distal collapse, is fundamental to recognizing the clinical presentation, radiological findings, and lethal vascular complications of an acute bowel obstruction. Let us precisely define this life-threatening GI condition. Intestinal obstruction is formally defined as a condition characterized by a partial or total mechanical or functional blockage, preventing the normal flow of intestinal contents through the lumen of the small or large bowel. To master this topic for clinical practice and board examinations, always remember the classic cascade summarized in our clinical workflow note. It all begins with a primary blockage. This blockage inevitably triggers proximal accumulation of intestinal gas, ingested water, pancreatic juice, and bile. As secretions build up within the closed loop or proximal segment, intraluminal pressure surges, leading to visible and severe abdominal distension. As the gut wall stretches beyond its physiological capacity, venous drainage becomes compromised, resulting in tissue edema and progressive bowel ischemia. If the ischemic process is not interrupted by swift medical or surgical intervention, cellular hypoxia progresses to tissue necrosis, bacterial translocation, gangrene, bowel perforation, and overwhelming sepsis. We must separate etiology into two major pathophysiological categories: mechanical obstruction versus functional paralytic ileus. Mechanical causes involve a true physical barrier impeding flow. The single most common cause of mechanical small bowel obstruction in post-surgical patients is postoperative adhesions. Fibrous bands of scar tissue form after abdominal surgery and can pinch or entrap bowel loops. Other critical mechanical causes include external or internal hernias, where bowel incarcerates within an anatomical defect, benign or malignant neoplastic tumors that narrow the lumen, volvulus, which is the pathological twisting of a loop of bowel upon its mesentery, intussusception, where one segment of intestine telescopes into an adjacent segment, gallstone ileus, where a gallstone erodes into the gut via a cholecystenteric fistula, fecal impactation or fecaloma, luminal. Strictures from chronic inflammatory conditions like Crohn's disease or tuberculosis, and swallowed foreign bodies. Now let us contrast mechanical causes with functional paralytic ileus. In functional ileus, there is no physical anatomical obstruction. Instead, peristalsis completely ceases due to neural, muscular, or metabolic failure. Common triggers include recent surgical manipulation, intra-abdominal inflammation like peritonitis, severe electrolyte imbalances, particularly hypokalemia and hyponatremia, neurogenic inhibition from anticholinergics or high-dose opioid analgesics, systemic sepsis, retroperitoneal hemorrhage, and critical medical illness. Let us trace the precise physiological domino effect detailed in this crucial key concept chart. Once obstruction establishes, digestive fluid and gas continuously accumulate, causing intense distension of proximal bowel loops. As intraluminal pressure exceeds capillary perfusion pressure, low-pressure venous return becomes severely impaired, leading to profound wall edema. This venous congestion compromises arterial blood flow, plunging the intestinal wall into tissue ischemia. Deprived of oxygen, the mucosal lining loses its structural integrity, allows rapid bacterial overgrowth, and permits live bacteria and endotoxins to translocate across the compromised wall into the peritoneal cavity and systemic circulation. If this high-pressure ischemic state remains untreated, strangulation occurs, cutting off arterial blood supply completely. Ischemic bowel rapidly progresses to full-thickness gangrenous necrosis, culminating in catastrophic bowel perforation and life-threatening stercal peritonitis. Recognizing the clinical presentation is vital for rapid emergency diagnosis. The classic cardinal triad consists of abdominal pain, vomiting, distension, and absolute constipation. The pain is characteristically colicky and intermittent in mechanical obstruction, reflecting intense hyperperistaltic smooth muscle contractions fighting against the barrier. Abdominal distension becomes progressively prominent, especially in lower bowel lesions. Nausea and early emesis are severe. As obstruction persists, stomach contents yield bilious yellow-green fluid, eventually progressing to feculent emesis due to bacterial overgrowth in stagnant small bowel contents. Absolute constipation, or obstipation, means the patient passes neither stool nor flatus. On physical examination in early stages, you may observe visible peristaltic waves and auscultate pathognomonic hyperactive, high-pitched, tinkling bowel sounds as gas and fluid rush through tight lamina. However, as bowel wall fatigue sets in or ischemia develops, bowel sounds become completely absent. Third space fluid sequestration and active emesis lead to profound dehydration, weakness, tachycardia, and hypertension. The development of abdominal rigidity, involuntary guarding, and rebound tenderness signals peritonitis and bowel ischemia. Differentiating small bowel obstruction from large bowel obstruction is a critical clinical skill. Small bowel obstruction is significantly more common, accounting for roughly 80% of all bowel blockages. The leading etiology in SBO is postoperative adhesions, followed closely by incarcerated hernias. Because the small intestine is located proximal in the GI tract, patients present with early, prominent, and frequent vomiting. Distension in SBO is typically mild to moderate and localized centrally. Auscultation reveals classical early high-pitched bowel sounds, and complete obstipation may be delayed until the distal colon fully evacuates. In contrast, large bowel obstruction is predominantly caused by colorectal carcinoma, followed by volvulus, especially sigmoid or cecal volvulus, and diverticular strictures. Because the colon sits distal to the ileocecal valve, vomiting occurs very late in LBO, if at all. Abdominal distension is marked, severe, and predominantly peripheral along the abdominal flanks. In LBO, complete obstipation and inability to pass flatus occur early in the disease process. Pay clinical attention to these red flags. In mechanical obstruction, pain is normally intermittent and colicky. However, if the pain transforms into severe, continuous, unremitting abdominal pain, suspect tissue ischemia and strangulation. Fever and unexplained tachycardia are sensitive indicators of systemic inflammatory response due to devitalized tissue. Physical signs of peritoneal irritation, such as muscular guarding, involuntary board-like rigidity, and completely absent bowel sounds, indicate that ischemic microperforation or transmural gangrene has occurred. Laboratory findings of a rapidly rising white blood cell count with a left shift, alongside metabolic acidosis with an elevated serum lactate, reflect tissue hypoperfusion. When you see these red flags, think strangulation immediately. This is a surgical emergency requiring immediate OR transfer. A systematic diagnostic evaluation must be initiated instantly. Plain upright abdominal radiographs are the initial screening modality, revealing classic stepladder dilated bowel loops and multiple intraluminal air fluid levels. Abdominal ultrasound can assist at the bedside in detecting structural causes or free fluid. However, the gold standard diagnostic imaging is a contrast-enhanced CT scan of the abdomen and pelvis. CT imaging precisely confirms the presence of obstruction, identifies the exact transition point where dilated bowel transitions to collapsed bowel, and determines etiology, such as tumor, volvulus, or closed-loop obstruction. Concurrently, laboratory panels must be ordered. A complete blood count evaluates leukocytosis indicating severe tissue necrosis. Serum electrolyte panels evaluate hypokalemia, hyponatremia, and hypochloremic metabolic alkalosis resulting from prolonged emesis. Arterial blood gas analysis measures base deficit and serum lactate to evaluate systemic tissue hypoperfusion. Early diagnosis prevents lethal ischemic complications. Patient management is divided into immediate conservative stabilization and definitive intervention. Initial conservative management, often summarized as dripping and sucking, begins with making the patient strictly nil by mouth-to-bowel rest. A nasogastric tube is inserted immediately and placed on continuous low suction. This decompresses the distended stomach and proximal bowel, alleviating emesis and reducing aspiration risk. Isotonic intravenous fluids are aggressively infused to restore intravascular volume, maintain renal perfusion, and correct electrolyte abnormalities. Non-opioid analgesics should be administered for pain control, while broad-spectrum for antibiotics are initiated if ischemia is suspected. Continuous close monitoring of vital signs, fluid balance, and serial abdominal examinations is mandatory. However, if conservative trial fails, or if the patient exhibits definitive surgical indications, definitive surgical management must occur without delay. Surgical procedures aim to relieve the obstruction via adhesiolysis or hernia repair. Non-viable gangrenous bowel segments are resected, followed by end-to-end primary surgical anastomosis or creation of a temporary stoma. Remember, any signs of peritonitis, strangulation, or bowel perforation require immediate, emergency exploratory laparotomy. Dedicated nursing care is critical to optimizing outcomes and preventing fatal complications in bowel obstruction. Primary nursing priorities begin with rigorous serial clinical assessments. Monitor vital signs and pain levels frequently. Sudden spikes in heart rate or temperature can indicate developing bowel ischemia. Strictly enforce absolute NPO status to prevent further bowel distension and aspiration. Maintain nasogastric tube patency by assessing tube position, irrigating as ordered, and meticulously measuring and recording color and quantity of drainage. Record accurate fluid input and output charts, monitoring hourly urine production via an indwelling urinary catheter to evaluate end-organ renal perfusion. Administer prescribed intravenous fluids, antiemetics, and parenteral analgesics, timing them carefully. Frequently palpate the abdomen to detect newly developing rigidity, localized rebound tenderness, or loss of bowel sounds. Provide supportive nursing care including skin care around the nares, frequent oral hygiene, positioning for comfort, and patient reassurance. Finally, rapidly prepare the patient preoperatively for emergency surgical intervention if conservative management fails. To conclude this educational masterclass, let us summarize key preventive strategies and critical takeaway notes. Prevention of bowel obstruction relies heavily on proactive clinical management. Early surgical repair of abdominal wall hernias prevents future tissue incarceration and strangulation. Encouraging adequate daily hydration, high-fiber dietary intake, and regular physical activity prevents severe fecal impaction. Early postoperative patient mobilization is essential to stimulate normal gastrointestinal motility and minimize adhesion formation, and aggressive medical management of underlying inflammatory gut conditions like Crohn's disease prevents luminal strictures. Always keep this vital rule in mind: any patient presenting with sudden, severe abdominal pain, bilious vomiting, and marked abdominal distension requires immediate emergency clinical evaluation. Rapid recognition, prompt gastric decompression, and timely surgical consultation save lives. Thank you for joining this masterclass. Stay curious, practice safely, and continue mastering your nursing practice.